Dr. Ngô Minh Hùng. We talk about the left main CTO after CABG, how to decide.
Yes, thank you very much for the introduction. Good morning, Chairperson, ladies and gentlemen. I think the topic should be changed a little bit. The CDO after the open heart surgery is better for the presentation. So nothing to disclose. So percutaneous inquiry intervention for chronic occlusion remains the most technically demanding procedure in interventional cardiology, and complexity is further heightened when the CDO is located at the aorta atrial segment and when the patient are elderly and history of previous open heart surgery. So usually the surgeon will send the patient to us and then ask us to do what we can do for the patient. They don't want to reopen the chest again because they replace the valve or they do the aortic replacement, and then that the indication in this situation. So I bring here two cases. The first one is the left main chronic total occlusion situated at the at an aorta atrial coronary segment in an elderly patient with a prior history of open heart surgery. This is the weak and CABG. We did the replacement of the aorta, ascending aorta, and then they do the bypass for the LED, but they not for the circumflex. And this is about medical history. That 64 years old male developed chest pain 1 year after the operation, and they on optimal medical treatment: cardiovascular risk factors, ex-smoker, dyslipidemia, hypertension, and diabetes. And past medical history, they had a with procedure done 1 year before, and limograph to LED to distal LED because they see that the LED had the lesion there. And currently, the patient has a stable angina with CCF class 3 and ECG, so normal aneurysm with the ejection fraction still preserved around 58%, with hypokinesia at the anterior wall and on the bottom means. And you can see that this is the EKG a little bit, the quality not very good, but you can see that the LV hypertrophy and the ejection fraction around 58% with the hypokinesia at the anterior wall. And this is the X-ray. The X-ray, so you have still see the cut there. And due to the just already had a lot of lesion from the proximal, mid, and distal also. So they put the graph. This is the angle before the procedure, before the operation. So they say that they had to put the cabin, put the graph to the LED, distal LED, in order to treat the distal LED, not for the proximal and for the circumflex. But actually, the circumflex still has a big territory of myocardium. So we don't know that the so this is the aorta. You can take a look at the aorta and measure the aorta. Measurement of the aorta is about 60 millimeter. It's quite big, and the patient had the symptom at that time, so they have to do the procedure like this. They replace the extending aorta, and then this is a picture after 1 year. So you preserve the left main, but 1 year later the left main disappear, and now we do the picture on this side. We don't see the left main, but still have the RCA. So this is very tough for us, and we did the angiography from the Lima. You can with the strong injection. With strong injection, so you can take. We can look at the distal left main there and the circumflex. Anyway, the patient had a chest pain and had a symptom, and on echo dobutamine also. So in this situation, I think the front door already closed. We don't know where. So we have to back door to go in, and we have to go from the Lima. So of course, according to this algorithm, so we have to go retrograde in order to try to open it and get some flow to the circumflex and proximal LED for the patient. And you can take a look what is the guiding catheter, and we go from the Lima to the LED, and then to the LED, and then go back up to the proximal LED. And we use the mic, this is the Corsair, and go up to the distal left main. But here the guy third couldn't poke through the lesion because very tough to go. It's the wire. I think we had to go direct to the aorta, but we don't know where the plug in order to poke. So finally, I use another wire, strong wire. And if we have the Gaia 4, so maybe I use the Gaia 4. No, the Gaia 4. But at that time, we have only the Comcast Pro. I think I use the Comcast Pro 20. Comcast 20, but now no more Comcast 20. So I try to poke the distal to poke the CTO body, and then finally about half an hour after point directly perpendicular with the vessel wall, but it's not there because the atrium of the left main maybe collapsed from the ulnar and from the coronary sinus, so the on top is the direction, the correct direction. So finally, we put the wire to the subclavian, and then extra exchange out to the another wire, and then open the left main with the 100% retrograde to the aorta without any antigrade. But of course, after that, we have to exchange the antigrade to stenting. Did they check the graph again and see the distal one? They did. So open the flow to the circumflex and proximal LED. With strong injection, you can go the flow back to the lima. But half that the lima still working, not closing after we open the left main. We don't know because sometimes we don't know the competing flow. So the second case, I think I already presented some time, and then I just put into this one 72 years old gentleman, and developed chest band. Uh, 1 year up to now, and then optimal medical treatment. The current the cardiovascular risk factor is dyslipidemia, as smoker. Past medical history is that they had the double valve replacement for 9 years already. So now they AFib also, and ejection fraction quite good, but hypokinesia at the septum. So you can see that the cut on the X-ray there, and they had the two valve replacement, the aorta and the mitral valve also. So they on anticoagulant. So this is the EKG, the AFib. So the patient have the symptoms. So we put the patient on the table and do the coronary injection. But this is the diagnostic catheter. It's still we don't know. We don't see the left main, but we have the right coronary artery. So strong injection, we can see the cholesterol from the right to the left side. It is a double valve, so we can see, go back to the left main. Of course, the front door now, once again, the front door is no more. We go from the back door, 100% with the protocol now. Of course, we use the right side to go to the back. And the surgeon sent this patient to us because they don't want to reopen the patient, this elderly guy. So 6 friends getting catheter from the radio, and 7 friends for the femoral in order to get the two SSI. And dual injection, this is a dual injection, but of course the left side we just inject the aorta, ascending aorta, not for engagement, with no clue, of the occlusion of the of the CTO. So yes, of course we see some cholesterol, so we have to use this way to go up, and we select some cholesterol, septal cholesterol. And once again, we look at it one, and of course we have to go and retrograde approach for 100%. Cut or reverse in this situation, of course, not indication because we have to use the balloon in order to do something, but it is go go the wire deletion through and through. Through and through mean go to the septal, and then go to the CTO, and then go to the guiding, not support from the antigrade guiding catheter. So we use the XTR to another two track to the left side, and then we go up to the distal CTO. During the procedures, the blood pressure going down, but we take a look, small injection to RCA, and we still see the T3 flow, but the patient going blood pressure drop from 120 to 90 millimeter mercury. So we look at it guiding catheter, this is AL catheter. So AL catheter is compressing on the valve. So we have to adjust the guiding catheter a little bit in order to stay away from the valve leaflet. And then we have in this situation we have to stop stop the use this guiding, we have to choose another one. So we use the JR guiding catheter, and we have to make a route. Again, the aortic wall, not on the valve leaflet. So luckily the Y go through the collateral, and then I send it out to the guy a second, and the guy a second they go through the CTO. As you can see, then they go back to the left main. This is the guy. This is the XDR, and then the micro catheter go up to the distal left main, and then we send it out to the guy a second, and then poke through the CTO with the guy a second, and I, we send to the go to the subclavian artery, and then capture the wire there, and yeah, ethanolization with the acid 330, and then snare it at this point because it narrow it at the smaller artery easier, so I use snare it. Use the blood flow to make the wire go to the subclavian artery. So at that first time we go to the left side, but after that we remove it and turn it to the right side and go let it go to the subclavian, and then they capture this. And of course, well, from here we do it as a normal manner. So the final shot show that it is the left main. It's a complex appear again. LEDs appear again, and they can, and the patient has no symptom after that. Of course, the mid LED has some sort of minor lesions there, but we don't want to treat that one. And this is my conclusion. Reopening the chest after open heart surgeries is a highly complex and high-risk operation. In such cases, BCI provides a viable alternative for complex occlusion of the left main coronary artery through controlled retrograde technique may be the only feasible approach. Thank you very much for your kind attention.
Thank you, Dr. Nomihyo.